Good afternoon, everybody. This is Anthony Nappi, the nurse liaison for the Virginia Impact Project, focused on infectious disease management and prevention across congregate care in the state of Virginia. Welcome to our 10th webinar. And we are excited as a team to kick off a three-part series on the management of chronic infections, specifically a focus on hepatitis C and HIV. And I'll introduce Dr. Laurie Archibald Pannoni right now. She's our medical director, and we'll get started. Thank you for your time and for attending.
Thank you, Anthony. Thanks so much to everybody for joining us today. We are excited to be joined by Dr. David Callendar. Dr. Callendar is a general internist at UVA with a focus on public health and medical education. He currently serves as an assistant professor of medicine, is board certified in internal medicine, and a fellow of the American College of Physicians. He's the medical director for the University Medical Associates in Charlottesville, where he provides personalized primary care to his patients and supervises internal medicine residents. He's a former military and State Department physician and has received numerous awards for clinical care and teaching. Originally from Virginia, Dr. Callendar served more than 7 years as an active duty physician, reaching the rank of major, and his training includes an internal medicine residency and additional graduate study where he received his Master's of Public Health degree and a Global Health Certificate. So we are really excited to have Dr. Callendar with us today to kick off our three-part series on chronic infections, and specifically he'll be talking today about the primary care perspective for hepatitis C and HIV. So thank you so much for joining us, Dr. Callendar. Take it away.
Well, thank you very much, Dr. Archibald Pannoni, as well as Anthony. I appreciate you guys inviting me, and glad to speak on the 10th iteration of this and kicking off a three-part series on hepatitis C and HIV is our particular grouping here. And I'm coming to everyone to talk to you a little bit about primary care perspective. And so I hope I can demonstrate the importance of primary care and as an initial touch point and guiding light to the care and management of hepatitis C and HIV patients. So again, all presentations with letting you know that I do not have any financial relationship about what I'm talking about, no commercial interest to disclose to you. So all of this is free of bias, and as otherwise mentioned by references that I'll provide is at times my own personal opinion that I will let you know about. So why was I asked to speak to you? I do have a background in public health, as you heard about. However, I also am a primary care physician, and specifically directing for the last 4 years the University Medical Associates. I think it's important for you to understand, what our clinic is to understand my perspective. And so we have a lot of patients, the largest ambulatory clinic in our health system, with 13,000 patients impaneled to us. And we do see a lot of patients each day, about 2,500 per month, which equates out to about 30,000 per year. Our patients are quite diverse. Many do not have insurance, and many speak Spanish as their primary language and have to have wraparound coverage services for those, as well as individuals. 39% of ours do not live locally, as defined as they have to drive over an hour. And many of our patients are quite complex, with your common medical conditions, including, diabetes and mental health issues. And many of our patients, almost a third, have 7 or more chronic illnesses. We focus on very comprehensive care for our patients with multiple pillars, which includes access for everybody, care for all, and education of our residents, so that we can grow the workforce of the future in primary care. I have a little statement here from one of our trainees I think really defines kind of the foundational experience they have taking care of patients that have come from different backgrounds and have a high burden of disease. And it makes it very challenging, but is also extremely, extremely rewarding. And so our clinic is not just about our patients, it's our team as well. We have a great group of long-term faculty who follow the care of our patients. There are 14 attached to us right now. They have many leadership and educational roles, as well as primary care physician roles. We also have a lot of residents in our clinic that come through here as their primary place that they learn to take care of patients. And we have a whole lot of support staff. It takes a village, and we have that village here. So we have diabetes educator, podiatrist that comes, psychiatrist, psychologist, an MP, LPNs, MAs, everything. And we're just off grounds here at University of Virginia, if you're familiar with it. We're right next to the Battle Building, which is a big glass building at 1222 JPA. We have 24 exam rooms. All right, so that is a little bit about us. Now, I was asked to speak about our IMPACT program. As you guys know, it's a collaboration between the School of Medicine as well as the Virginia Department of Health and telehealth services in the Mid-Atlantic to kind of describe and think forward towards infectious diseases in various settings across the Commonwealth. And I think it's very important to understand in primary care hepatitis C and HIV. So I mentioned us in primary care being the guiding light to our patients, but one of our foundational aspects of where we direct our care, as you guys probably know, is USPSTF, which is the guideline that we really provide the most solid care to our patients and education to our residents. You all may be familiar with grade A and B recommendations, and those are the ones that we focus on here. Unfortunately, fortunately, there are a lot of grade A and B recommendations, as you can see here. And so as we navigate a complex care, we often in primary care come up with screening for our patients in HIV and hepatitis C. So my first question here is that guided by the USPSTF in June 2019, HIV screening was either recommended in those not previously screened, less than 65, less than 65 if written consent, or high-risk adults only, or there is insufficient evidence. So do we have an option for people to respond, or I'll certainly give time to think about this.
Yeah, people can go ahead and unmute if they want to join the discussion, or go ahead and put your answer in the chat. We would love to hear from you. All right, we've got a vote for A.
Nice. So thank you for the person that voted for A. That is the correct answer. The reason I bring this up is actually an interesting topic that's probably near and dear to all of us. I was waiting for the years when I said back in my training. So I'm, middle to late, coming up into 15 to 20 years past my training. And I remember we used to have to get written consent for individuals just to do the HIV screening. And that didn't sit well with me then. And I happened to be in a state where we were obligated to do it. As you guys all remember where we were coming from in the 1980s, there was a lot of angst in testing people and what it meant for somebody for HIV and how solid that testing was, as well as what we would do with it. And as of 2006, actually, there were still 20 states that required written consent that was signed by a patient prior to get HIV testing. And it was not until the 2010s that states really stopped doing that. And actually, New York, 2014, and Nebraska was the last holdout in 2018. So certainly we don't have to do that anymore. So this is how we might engage with patients who we identify have HIV is we're just doing routine screening, great primary care. So now what do we do? I really want to have you understand that there's a lot of strategies to utilize to really take care of patients and build a relationship with them, as well as manage them for the future. And I do think it's the role of the primary care physician to do these things. And so I've learned a lot over the years that building rapport is extremely important for caring for patients. This is a point where, respecting an individual's pronouns and being thoughtful and inquisitive. one of the most important things with building rapport that I always try to talk about in presentations or in anything is leaving time for people to tell their story. And you may have seen a couple minutes ago when I asked people to answer a question, I didn't answer the question myself. Despite no one responding, I still stayed there for a while. And one person responded. Maybe your patient will tell their story if you give them a little bit of time. So that's one strong way to build rapport, is to just be present and say less. And with that, I think you really want to understand the individual's background, which again is at times saying less. As we know, the initial diagnosis and circumstances that led to someone contracting HIV could be extremely traumatic. It's not a point to probe to show that you care. It's to just be there and be present with them. And then also always respect privacy, I've learned. I've run into a few situations in primary care where I expect a listening party in that room behind the door with the patient, knows exactly what's going on, and it might not be their place to know that information. So certainly ask if it's a place to bring this up. We like to think someone's there for a reason, but sometimes they're not. So anyhow, those are my key points to establish a great relationship with a patient. All right, moving on to prevention and screening in those with HIV. I always teach, there's a few articles I have here, and I have references at the end that really there is a higher risk of cardiovascular disease for individuals who have HIV. And it's an extremely important opportunity to screen individuals for cholesterol, diabetes, and blood pressure. I think we all know that a diagnosis of HIV is just a chronic condition, not just, but is an additional chronic condition for an individual that does not overly impact their life expectancy to the degree certainly that it did decades ago. So it's important to focus on these screening, one, because people are at higher risk, but also to manage them long term. And then certainly take the opportunity for smoking cessation for these individuals. I want to move on to the history taking. Despite the advent of artificial intelligence, there's always going to be us in using our clinical gestalt that can never be replicated. So always remember side effects of medications. Many of our medications have gotten better over the years. It is great that we have, different medications that can be given long term, not even, multiple times a day, but once a day or even less for chronic medical conditions, including HIV. And so despite that, there are still side effects, and just be cognizant of that. If you're taking care of a patient, they're being prescribed a medication from a subspecialist who specializes in infectious disease and HIV care, make sure you know what those side effects might be so that you can listen thoughtfully to your patient. And that's your role in primary care, to do that. And then understand medication interaction. I just added a couple here, speaking to the point of identifying individuals with HIV who have diabetes and hyperlipidemia is certainly to, know that there are often many side effects related to use of those medications with interactions with their HIV medications. And then always focus on mental health. And I have an article here that I thought was very good, and wanted to mention that, you can look at different data sources, but approximately 2 times as likely for individuals with HIV to have depression. So certainly focus on mental health services for individuals. I know those are limited across the Commonwealth and the nation in a whole. And I mean, my clinic, as I mentioned, we are fortunate to have an embedded behavioral health team that works with us and take care of those almost 1/3 of our patients that have mental health care needs. But this is another population that has even more. And so something to focus on as you're carefully doing a PHQ-2 and PHQ-9 on your patients, is being very thoughtful about it. All right, so moving on to physical examination. There was a lot I could talk about here. I did want to mention, particularly as an interest of mine, is eye conditions from personal experiences in general, just in general. So I always focus a little bit on the eyes. And so there's keratoconjunctivitis or dry eyes, SICA, that occur in about 20% of patients with HIV. So I think that would be extremely important to focus on, is ensuring that someone has great eye care, as well as their skin, evaluating their skin for different inflammatory conditions or malignancies, depending on where they are in their management and control of their HIV. And you can see an article that I have referenced here. And then always points in disease progression, looking at any fevers, weight loss, or problems with enlarged lymph nodes. All right, moving on to preventative measures. Really want to mention that treatment of HIV and being very connected with your patient and ensuring that they are taking their treatment is also a mode of HIV prevention. It is makes it, as you know, less transmissible. And so treating HIV aggressively and following through with the patient taking their medications is something that can really decrease the transmission. So something to focus on in primary care. My next point that I wanted to mention in preventative measures is post-exposure prophylaxis. And this is to prevent other, certainly other conditions for an individual. And this is 200 milligrams of doxycycline within 72 hours of condomless sexual activity, is an important topic that has become well known over the last couple years and is something that you should take into consideration in certain patient populations. And then cancer screening and vaccinations overarching are extremely important in all patients by USPSTF guidelines, but also certainly in patients with living with HIV. And it's very important to be up to date on all of these, as well as vaccinations, in particular to pneumonia and HPV. Here are my references that I have included related to HIV. And these can be available to you, after this presentation. All right, moving on to hepatitis C in primary care. So I wanted to emphasize the importance of hepatitis C in primary care and when not to refer people. So what is USPSTF's recommendation for hepatitis C screening? So do they recommend against screening? There's insufficient evidence. All adults once born between 45 and 65. All adults up to the age of 79. Or screen only high risk, such as IV drug use and tattoos.
Like
You
we
guys
have
are, what is that?
some split voting here between C and D.
Nice. That's as expected. When I present this in different avenues, I often see people that mention those two options. People don't want to dabble in the insufficient evidence sort of thing or the against screening. Why would I be presenting something? And I love screening and things, but anyhow. So the answer is D. In March of 2020, the USPSTF updated their recommendations, which before that was to screen the baby boomer generation, which was 1945 to 1965. The reason it expanded it was that, yes, the baby boomer generation was a large group of individuals who were exposed to hepatitis C in particular, and tattoo parlors that were not having certain practices of sterility. There was a non-sterile environment, as well as not screening blood banks back in the before the 90s, and then as well as common risk factors like sex work and things like that. or just high-risk sexual activity. We found that actually 45% of people who did have hepatitis C did not report any of those common risk factors, and therefore it was felt that a large group of individuals were being, and they were, based on the data, being missed. Therefore, it was protective for the general population and for each individual to be tested independent of risk factors. And so generally patients do pretty well with this, honestly, in my own primary care practice. We use electronic medical record, which you guys are probably familiar with, which is called Epic. Epic, in my opinion, is a great electronic medical record. I think it's really has a lot of good interfaces to it. And so on the left side of a screen is a blue area, which I have represented here in a picture, and that's called the storyboard, which sits in front of a patient's chart, though people don't usually perceive it as that. It's something that can always be there, and you can hover over different things. They did add this hepatitis C antibody screening after these recommendations came out at the University of Virginia. I believe probably the year after that in 2021, but don't quote me on that. And when they added it, they saw the rate of hepatitis C screening go up immensely. We would like to think it's because people reviewed the literature and certainly had time to think as the pandemic was wearing on about USPSTF recommendations, but really it was a simple interface platform where you would hover over in the storyboard that said that hepatitis C antibody was due, and then they could click that green check mark there, and it would order the test for the individual and tie the diagnosis of hepatitis C screening to them to meet all criteria for insurance purposes. And so it just made it easy for us to do this. So with that being said, I think it's made it very easy for us to screen for hepatitis C in primary care. And I have been, I will just tell you personally, surprised at results at times, and it really speaks towards the fact that maybe in the past, when I was asking questions, screening questions, I wasn't thinking about holistically about all patients and the patients that might not be revealing to me those screening positivity because they either weren't comfortable or they just didn't remember, which speaks to my point at the earlier part of this presentation where building a relationship with patients is extremely important in primary care so that patients can be vulnerable, they can be fully transparent with you, and you can be honest with them as what you're trying to accomplish during a visit. So anyways, with that being said, in primary care, we certainly screen for hepatitis C, and as aforementioned, all adults should be screened at least once. There's consensus across these different organizations, and I did mention that 45% that's listed here. And so people that are of higher risk, which I have listed here as well, you would consider screening at some period of time, depending on what guidelines you might review. That could be yearly. I'm not going to speak towards those directly, but I don't want you to take away that if an individual is screened one time, they should never be screened again. Certainly, it's not a static, it's a dynamic process throughout someone's life. But I just want to present this as just a garden variety patient who is of a certain age. We're screening them, and now they have a positive test. It's probably well known to most people that a good screening test is going to pick up cases that are positive and mainly get rid of cases actually that do not exist, and that's the foundation of screening. And then take those cases that we do believe now are positive and take a second test on top of that that is more able to identify that somebody actually does have a condition. And I bring that up because it's extremely important to do a two-part testing, particularly in your system, to do a reflex testing where there's not input from you as a user, or that the patient has to come back. And the important for that is that you get a positive antibody screen, and just because you have a positive antibody screen doesn't mean that you have hepatitis C. It can mean a lot of things, which we'll go over on the next slide. And to really confirm that someone actually has active hepatitis C, you get a secondary test, which helps identify exactly what's going on, which would be the reflex test to the viral load. they have found, and I have some articles here, that if we don't do it this way, we get a lot of patients who are unfortunately lost to follow-up. And the intent was for this prescribing provider to have that patient follow up and to get that testing, but sometimes it doesn't happen. So really, I do encourage that reflex testing. It makes things quite easy. I wanted to put a plug in for outreach to different community organizations, specifically methadone clinics, STD clinics, and even syringe exchanges, where screening for hepatitis C would be a very good use of everyone's time in public health perspective in those entities, if you can implement that. And there's a lot of success that's reported in the literature on that. So I'll come back to establishing that relationship with a patient. As you're giving a time for the patient to speak, you are going to be speaking too, and you want to ensure that what language you're using is extremely important. As I've mentioned, having a positive antibody test does not mean that an individual has active infection. And so almost 50% of individuals can spontaneously clear, and then they can have a positive antibody test and they don't have hepatitis C active anymore. So I have some aspects of someone's history that could make it more likely that they would spontaneously clear. If a patient was to ask you, why did I spontaneously, why did this happen to me? Why do I have this? You can think about some predispositions, such as the ones listed here, that you could share with your patient. All right, so treatment pearls. So actually right now, I'm coming to you as a general internal medicine doctor, but I also spend 6 weeks on inpatient service. I'm currently working on the 5th floor of UVA Hospital. Traditionally, we've had a gastroenterology service where we have a lot of liver failure patients on the 5th floor. And probably about 10 or 15 years ago, things switched. We had so many patients who were on that service from hepatitis C. Now it is much more who are not that, but related to the new term is SLD, which is steatotic liver disease, which traditionally is NAFLD or NASH, non-alcoholic steatohepatitis. These are the individuals who have liver failure, but it used to be hepatitis C patients. You guys all probably know that we came out with these amazing drugs. They were very expensive. Maybe there was some question on who to treat and who not to treat. What was the best thing to do? And really, we want to treat everybody because we want to stop the progression to liver failure and need for liver transplant, which it's threading a thin needle, because oftentimes we have to be sick enough to get the transplant, but we can't be too sick that you can't get the transplant. And we can prevent all of this from just treating someone. So that's going to be if a patient says, well, what do I do now? It's you get treated. That's what you do. It's just the best thing to do. And yeah, so also I have here listing models with 90% reduction incidence by 2030 as a goal. And then again, mental health is extremely important in this patient population. And so with treatment, we're talking about the C word, which we often don't do in medical conditions, which is cure. How do you define cure? Well, I'm not going to go into that totally, but these kind of seem like cure. No treatment monitoring is required. The side effects, which is no treatment monitoring after, which I'll go over in a second, but you give the person the med and they're pretty much good. There's some nuances to it though that we'll go over further later on in these presentations, but not mine today. Traditionally the medications that were prescribed had many side effects. These do not. Your typical fatigue, nausea, and headache, which are self-limited often and do not change the management or what is needed to be given. But sustained viral response at 12 weeks happens in the vast majority of individuals. And when you identify that, the person is cured, which is a great perspective to have. That's a short time period. People are given med, they do great. Now, when to refer to a specialist? Some people, have problems where, despite the treatment, their viral load would be detectable, so they did not have that SVR12. They have evidence of liver failure, and there's a lot of stigmata to liver failure. There's the imaging and laboratory work that can indicate liver failure. If an individual has this, they would need to go to a hepatologist. If someone has a co-infection with something like hepatitis B or HIV, they would need to go to a specialist in infectious disease. The reason why would be that the treatment for hepatitis C, some aspects of it can cause problems with those co-infections or impact the management, and they'd have to be carefully considered outside the scope of a primary care physician. But otherwise, the primary care doctor can do really well with this in a systematic and thoughtful process. I did want to mention one slide on the integration of care. And this speaks a little bit of, coordinating the care between individuals in addiction medicine, as well as the treatment of hepatitis C and opioid use disorder. You probably can guess my opinion about treating individuals who are still at high risk, and that is to treat them, even if they are current injection drug users. Really, I've run into this too, is adherence to treatment is extremely important. But if you can get that rapport with a patient and get them to adhere to treatment, they're going to do great. And so that's where the primary care role or the connection with the patient is extremely important. And then we find that reinfection is actually quite low, which was surprising when I've learned about that. So integration and care across these models is extremely important. And here are some more references and guidelines related to that topic. So, questions?
Feel free to unmute to ask a question, or if you want to put that in the chat, we'd love to hear your experiences, your thoughts, your questions today. To respond specifically, will we share the slides? Yes. Anthony, do you want to talk about that a little bit?
Sure. Yeah. So typically, when I do a follow-up email, we'll share a link to the recording with all the slides.
Yeah.
I have a question. Hold on, let me mute my coworker.
You can definitely type out what you were going to ask. That's fine. And then I did speak towards the treatment of patients who are still active drug users, but that is a good question to think about there. Any other questions as Elizabeth types up what she's going to say? So just for the group, Elizabeth asked, for those with immune-related toxicities and ART, which is active retroviral therapy, with steroids being treatment of choice, how would you go about that? Well, Elizabeth, I'd like to ask a second. It's hard when you ask a question, I ask you a question back. So you're stating for those individuals you would give steroids. However, you're wondering how you would, let me think, for immune-mediated related toxicities and ART therapy. Choice, how would you go about that? I think in particular for that question, this would be a time as a primary care physician to be engaging a a HIV doctor who kind of specializes in some of those toxicities. I mentioned earlier that side effects of either intolerances or side effects is versus toxicities, especially with the immune system. I'm of the opinion that collaborating across specialties is extremely important. So I don't have an answer of what you should do, other than you should ask for help. Um, yeah, I'm people who know me, I love asking for help and assistance. I think I learn a lot from it. Exactly. So I'm glad you guys do that as well.
I would just add to that. I think that, as a primary care provider, as a generalist, it's important to engage our colleagues in subspecialty care when the need comes up. We'll also be talking a little bit more in depth about hepatitis C and HIV with specific condition-related specialists in the next 2 months as well.
Yeah, the way what I was thinking about, as this group of three speakers come, is to just try to lay the touch points on where you're going to engage with a patient. And I don't think it's ever like this is your deal or my deal. It is our deal together with the patient, and it's a triad. Oftentimes, I mean, sometimes it can be the primary care physician and the first care provider and the patient, but oftentimes it's a discussion between three. When I send a simple referral for different things to say orthopedics, I say, this is your deal. I'm not dealing with this. But this is an example of where we will follow along, each of us together, and collaborate. And Tidra, thank you so much. That was my own personal opinion, and I'm glad you agree with that, because I am constantly surprised about my biases, though they come from a good place, but sometimes they're ingrained over many years. So this is the benefit of universal routine screening that cuts that out.
Yeah, as well as the importance of epidemiologic data, right? To look at the data broadly and really identify those areas for how can we be doing this better. I think it's a really important piece of that as well. And then doing it better. So thank you for highlighting that as well.
Dr. Callendar, a question with respect to the context of congregate settings or long-term care settings. What is the risk or transmissibility of hepatitis C among patients in close proximity, eating together and living in the same room and that kind of thing? Is there a significant risk associated there?
No, so this is going to be different than, say, other infectious diseases that are transmissible, like through respiratory route or something like that. So if you think about like the risk in those settings for tuberculosis, when we think about these sort of risks, is certainly you can think about individuals in close proximity, such as sharing a toothbrush. It is still quite rare to contract something like this in that situation. Going to my own personal experience, I have had a patient who did contract hepatitis C from sharing a toothbrush with their now passed brother, who has passed away. But the point is that it is safe to be in an environment with other individuals with these conditions, and you probably already are. And so I don't think you're doing a disservice as long as you have a great outreach to your community and who you're working with. And like an awareness is that you're not putting people in buckets where they're going to be overly concerned or biased in a certain way, where they're going to be mistreated from other individuals, because truly it is safe to be in these environments, and they already are together often. So Anthony, I hope that answers some of your question.
It does. Thank you.
Sam, for the group, Sam asked co-infection between hepatitis B and C, and how I mentioned if someone has hepatitis C and then they also have a co-infection with something like hepatitis B, I'd be referring them to care and management for a specialty care. And what are some best practices for looking out for reactivation as part of the patient relationship? And so an individual who has chronic hepatitis B and is on like weekly therapy, anything that could, and then they got treated for hepatitis C and cured, individuals that then have, that medication that they're taking, they could be at risk for reactivation or they just had hepatitis C and they're not being treated if they have any immunosuppressing conditions, like say they developed cancer and they're on, different immunomodulators and for other conditions where these individuals would be at risk for reactivation of something like hepatitis B, or if they were not adherent and not treated fully to hepatitis C virus. And so understanding someone's status with all of these and where they are in their course of their treatment to cure or treatment long-term or is very important. And there's a lot of nuances with hepatitis B and hepatitis C. With how a body responds to it and if it sets up shop inside their body for a long period of time or does not. So I guess every case is unique, but certainly understanding what someone's treatment has been and where they are right now in their overall medical conditions is really important in primary care, as you can, take care of your patient over a long period of time. Thank you, Sam, for that question.
Me again, Dr. Callendar.
Yeah.
Wondering if you had any thoughts about, again, in the context of long-term care, any strategies among the wider team with respect to adherence to treatment over, I guess it's like a 12-week period of time.
Yeah. So when some of my background is in global health and looking at different models of caring for people with, I don't know, something else is why I brought it up again, but tuberculosis is directly observed treatment or therapy, is that DOT, isn't probably the best relationship building with individuals. Patients often are ultimately responsible for their care and management and taking some ownership. So I do feel that patients should be ultimately responsible for the care and management of their medication. But adherence can have some secondary factors, like is someone making their visits? Could you have different touch points that are outside the clinical if you're in a congregate setting where you're just engaging with an individual and making sure nothing has changed in their life or what they're doing. Fill histories and outreach and navigation through nursing is also something that is very helpful. Because these are costly medications. So I do feel like we shouldn't just direct a patient that they must do this or observe it, is that we do try to ensure that the patient is getting the medications and is taking them. So multiple touch points across ancillary team members from nursing to different team members in any setting is going to be extremely important to ensure that someone's adherent to something that is definitely going to cure them. Well, not definitely, but is most likely going to cure them if they just take the medication.
And do you know of is there any literature that would that looks into like an unfinished course of treatment for hepatitis C, where maybe someone adheres to it for sporadically or for the first half of it?
Yeah. So like with any treatment, doing a full course is going to be the best. You could even do more than that full course, but that would be an excess and it would be cost prohibitive. You could have a certain percentage on some sort of curve. It's not a bell curve in this situation, but it's past a critical point maybe where someone could respond really well early on and they could be fine. And so I think it's just a balance, and every organization is going to be a little different. Is if if you took this much of a medication and you have identified that you have resolved your viral load over a certain period of time, I think, at least again, this is my opinion, is that you would be cured. And that would be a great time to collaborate with an infectious disease doctor about that and ask that specific question. They may have that specific guideline that could, and I don't think there would really be one. And it would just be a balance. And everyone has tolerance for, with all medical conditions, like what they want to say. They're like, nope, we got to start over again. But see, that's really expensive. So yeah, that's a great question too for when next part of our series.
Thank you.
I do have a question just about kind of your experience with these conversations with your patients over, the past couple of decades almost, in terms of how have you seen these conversations evolving in terms of screening for hepatitis C, screening for HIV, and then kind of getting those results? How have you seen those conversations really evolve over the past few decades?
Yeah, I appreciate that question. Let me think. So I've actually thought about that, speaking specifically to residents about this. And so let me think, honestly, so patients used to say, like, no, I didn't with hepatitis C. No, I didn't. I did not go to a tattoo parlor. I have no tattoos. I have never drank or smoked or injected anything. I've always never been altered and someone did something to me. I've done everything safe. I've never cussed. I'm not a sailor. But now I say, great, I'm so glad. Guess what? I think it's really important to check your hepatitis C antibody because you never know about anything. And I just go right through that and I just say, this is an amazing test. It is so good. Like, if you always would want to try to figure out if you have something and get treated, right? And they're like, I do. And I was like, I'm going to test you. But probably like years ago, I used to say, good point. All right. And so I think this is where reading into the literature and understanding a little bit about the incidence and the epidemiology and that group of people who, public health speaking, like stepping away from the individual patient's concern and not being biased from what they're saying and just saying, hey, like, let's be part of the solution and just get tested and we won't have to worry about that. And so the same thing, I don't have as a robust of an example, but I think I could think right through that with HIV as well. But it was just very like enlightening to me years ago when I realized that this is the crux of primary care and public health, is like, you just screen. Like, it's great. Like, it's good information to have. It keeps you the safest person possible. Instead of explaining away the prevention, which I don't think we should do. Like, oh, I don't have colon cancer because nobody has colon cancer around me. I don't know. It's like that sort of a thought process I don't think is the most valid. But I won't talk about colon cancer screening today.
Fair enough, fair enough. And I think it's, an important part of that conversation, especially now in the past few years, we have great treatments for these infections. And so being able to identify early, ideally asymptomatic people, being able to really intervene and prevent those long-term consequences, whether that be, liver failure or some sort of catastrophic infection. We have great treatments, and getting those to the people early, getting those to our patients early is a really important part of this. And so I think it's been a really exciting kind of evolution of medical practice over the past couple of decades to think about, back when, gosh, if we find the answer to this test, what are we going to do about it? And now, okay, well, this is what we're going to do about it. Now we have those answers. And so it's great to have those tools and to make sure that we understand that we have those tools, and so that we should be screening our patients and then getting them into situations where they can be treated for those infections. I think it's really important. So thank you for addressing that.
Yeah, absolutely, Lori. I didn't mention that all the way. Absolutely. Yeah, exactly what you're saying.
Other questions from the group? All right, well, seeing none, Dr. Callendar, thank you so much for joining us today. We really appreciate you sharing your perspective from a primary care provider's opinion of, or not opinion, but data and opinion on these kind of how to understand them better for our patient population and then how to take that forward in practice. So thanks so much for joining us. As mentioned, our next two series will focus in more detail from the subspecialty standpoint in terms of resources that are available. How do we treat our patients? What are these treatments that we've been talking about? And how do we get our patients into these types of treatments and different tools for improving outcomes? We'll talk about hepatitis C with Dr. Dillingham in May at the May session, and then we'll be talking about HIV and tools and technology that have been shown to have improved outcomes with that as well. So with that, I will hand it back to Anthony to wrap us up.
Great. So this is a slide with some instructions on how to obtain your CME credit. And this will also be included in the post-webinar mailing over the next few days so that everyone has a link to the recording and the slides and the CME credit. The follow-up, the next two sessions, the May session is May 15th and June session is June 12th from 12:30 to 1:30. And then finally, I always plug kind of the other focus of our Virginia Impact team's priorities really is telehealth optimization or improvement or initiation across congregate settings. So if anyone is representing a facility who would be interested in an assessment of current telehealth use and perhaps a conversation on optimization of that, we would be happy to do that. It's we're a grant funded project through Virginia Department of Health, so it's we're fully supported and it's free of charge, and so we'd be happy to have further conversations along those lines. So I appreciate everyone's time today. Dr. Callendar, thank you so much for
You're welcome.
sharing your expertise and a great conversation, and wish everyone well this afternoon.
Thanks so much. Hope to see you next month.